All right, guys, don't worry too much if you haven't finished all of those questions. We'll tidy up any gaps within the group right now. So talk to me about some of these growth and development principles. So what is meant by cephalocaudal? Summarise that principle for me in your own words. Someone like to take a swing at this one? Yep, finish that off. You're right. Or would someone like to help me out to finish it off? Yeah, so if you think about a learning strategy for this, remember I flashed up a few images of what a fetus and a newborn baby looks like compared to later on. What was the most outstanding feature of the early years? The massive head. So development happens more with the head and I guess you could say the axial skeleton and then out into the appendages. Second principle, proximo-distal. What was your summary? Yeah, from the centre out. So give me an example of how that plays out in child development. Yeah, exactly. I actually remember my daughter, and I can't remember how old she was. They go through this stage where they work out that this thing is theirs and they can actually control it when they hit that distal stage. So they start to move around here and the arms move and all that sort of jazz. But I remember her being fixated like this for about 2 minutes continuously. Just this look of amazement on her face and wiggling her fingers. Like that's when she joined the dots. That this thing belongs to me. That's how I remember proximo-distal. Hierarchical integration. Fancy term, but it's actually quite simple as a principle. Good. So simple before complex. So give me a practical example of that.
I guess they can learn to move their fingers before they can actually grasp something.
Yeah, that's not a bad example.
Learn to pick up a ball versus learning to catch balls.
Yes, that has more dexterity and control required. Exactly right. Do you remember the example we gave last week when we were explaining this particular principle? Yeah, the layup of a basketball. So unpack that for me. So the layup of a basketball all put together is quite a complex skill, including running up to the hoop, bouncing the ball simultaneously, single leg takeoff, and then actually get the ball in the hoop with this sort of side action. But if we were to break that down, what are some of the more simple skills that are pieced together to produce that complex movement? Running, jumping or single leg jump, yep. Bouncing the ball and having the hand-eye coordination to release the ball at the right time so it goes into the hoop. So it's essentially a series of simple skills that are chained together is what we refer to. So if you ever want to coach a complex skill, be it in the weight room or working with kids down on the oval or whatever context, you just generally try and break it down. You remember your PE lessons, golf swing. You never start by saying, oh, kids, there's a ball, go for it, hit it as far as you can. You've got to break it down and teach the simple skills in isolation, then you blend the whole thing together. Independence of body systems.
The idea that different body parts grow at different rates.
Different body parts, yeah. So that's within a system or systems. You're thinking of the example we spoke about last week, which was? We spoke about the muscular system and its rate of development versus the skeletal system. Yeah, so that's another sort of macro view. So right here, I drew the picture of the person and we had all of the systems represented by arrows. And we said that different systems mature and develop at different rates. So it doesn't mean that the muscular system, the skeletal system, the urinary system, the gastrointestinal system, all of those 11 systems of the body, they don't kind of grow in a linear fashion all at the same rate. There's some difference there. And the example we spoke about was how the muscular and the skeletal system mature at different rates that produce some growing pain issues for kids in middle childhood and adolescence. Do you remember the two examples we spoke about? Yeah, beautiful. Osgood-Schlater's disease, which was here. And the second one, Sever's disease. Beautiful. So talk to me about what those conditions actually were. They're inflammatory conditions rather than acute. But why? What's the physiology behind those two conditions? Perfectly articulated. What grows faster? The muscles. You had a 50% chance. It's the tendon that grows faster than the bone or the skeletal system. So it's exerting this stronger force of pull on the attachment site. And as a result, the bone's like, holy moly, what's going on here? And it results in an inflammatory response. So as a case in point, if you've got a kid with Osgood-Schlatter's, this tibial tuberosity here, right, this bump below the patella gets so tender and so sore. And if you get a kid like that and you get them to do some volleyball or basketball drills with high impact and jumping, they won't be your friend for very long because it will hurt. I had this when I was about 11 or 12. No, 10 or 11. And it wasn't fun. Kneeling down was excruciating and you just get this dull ache. It's not fun. And the same with Sever's disease with kids. I saw a kid with this 2 weeks ago, and putting on soccer boots and running caused him all sorts of pain the next day. So it got sore towards the end of his soccer training session, but the next day was pretty painful for this kid. Soccer boots aren't very shock absorptive, should you say, and some of the fields around here are pretty hard at the moment because we haven't had that much rain over summer. So a combination of a few things, first couple of training sessions, so his training load's gone up suddenly, resulted in an increase in inflammation. All right, periods or stages of growth and development, we've covered off on those. One characteristic from each. So talk to me about one for infancy.
Object permanence.
Sorry?
Object permanence.
Yeah, so talk to me about that. Provide the good example last week, but you remember it? The teddy bear.
Yeah, like when you cover it up and it's still different.
Yeah, exactly. So in the early stages of infancy, just to reiterate that, if you take a teddy bear or an object away from an infant, then they believe that it is no longer in existence. That is gone, it's out of sight, it doesn't exist. Whereas object permanence, when that starts to develop, then they realise that it's still a thing, but it's just not where they can see it. So they start to realise that just because I can't see it doesn't mean it doesn't exist. Nicely done. All right, what about for early childhood? Yes, in some instances. What was your point? Yeah, so tell me how that plays out.
So they're looking up, so they're realising what they can and can't do, what they'll get in trouble for.
Yeah, okay, so they understand that certain actions or behaviours start to have a consequence, whether it be praise or whether it be punishment. Yeah, nice. What about late childhood? Yeah, so talk to me more about that, unpack that. Yeah, yep. That kind of starts during late childhood and sort of goes into adolescence, isn't it? That search of identity and who I am and... Sometimes that's an operative term, isn't it? During that late childhood stage, who do they start to seek approval from? Yeah, from peers and teachers. So early childhood, who do they seek approval from most often? It's parents or significant caregivers. I should use the politically correct term. But then during late childhood, it becomes some significant others like the coach. Remember I used the example of my daughter? I try and get her to do something with respect to netball. If I tell her to do it, she'll tell me to go jump in the lake. But if a coach tells her to do it, well, then she'll do it 100 times. All right, what about adolescence? What have we got as one characteristic for that stage? Sorry? Puberty. Puberty. So what happens during puberty? Yeah. So we have the development of secondary sex characteristics, and what is the main driver behind those? Hormones. Yep. Enough said. Early adulthood. Physical peak, so physiological peak. So in terms of what sort of characteristics tend to peak during this stage? So muscular strength. Yeah, reflexes, you'd hoping they've been developed by now, but you've certainly probably got a greater window to optimise their function. Yeah, what else? Paul? Working, okay, so talk to me about career. This is a different kind of category. So this is when we first start working. We sort of say early adulthood, early career. So this is about entering the workforce and realising the independence that might come with that because, oh, I've got a stream of income now. Oh, maybe I can move out from home and get my own place and have some independence and experiment with different things. All right, middle. What happens in middle adulthood, 40 to 65? Oh, hell. Otherwise known as a midlife crisis. That plays out very differently from person to person. What about if we follow the career analogy on, what are we about in this middle stage? Yeah, so you're probably reaching your peak earning power. So you often, and I mentioned I feel this now as well because I sit just in that middle, operative word, just in that middle adulthood stage. But you feel like, well, I'm feeling a certain degree of mastery over my trade or vocation. So naturally you start climbing into middle management and higher management and things start happening because you've been in the game for 20 years or so. So there's always this conflict between, well, I feel I really want to build my career because I feel I know what I'm doing and I enjoy what I'm doing and this is what I'm going to do. And then you have family. So you have kids that are sort of late adulthood, maybe adolescents. You think, well, how do I juggle the both? There's this kind of internal conflict going on. I can speak firsthand around that. Yeah, that's an interesting one. So tell me the complexities that might surround that. Yeah, absolutely. So you're torn from a family situation at top and bottom, if you like. You've got your kids that are younger and you've got your parents and you're managing, perhaps transitioning them into aged care facilities and they have chronic health conditions and they don't want to go into a home, but, you know, they need something like that for care and there might be complexities around maybe mum is doing really well, but dad not so mum's caring for dad and so on and so forth. There's lots of emotional stress that surrounds that, isn't there? Yeah, tricky period. Late adulthood. Talk to me about a characteristic there. Legacy, yeah. Unpack that for me. What does that mean?
What am I going to leave behind?
Yeah. What is my legacy? What stamp have I put on society? When I go, what am I going to be remembered for? So this is one of the stages of growth and development. That can play out one of two ways, can't it? Remember we looked at one of the stages of growth and development. So if you look back on your legacy and you're pretty pleased or satisfied with what you've achieved so far up to this point in time, how do you think that would reflect on your general well-being? Yeah. So from a psychosocial perspective, you're probably more satisfied and you're probably better equipped to enter that later stage of adulthood, which by now, as we know from our previous conversation, can go up to 85 plus. So it's a fair chunk of time. We almost wonder whether this will be split into early, late and late adulthood at some point in the future. What about physically? Yeah, yep, decrease in physical strength, muscular strength. So leading back to sarcopenia, which increases the risk of what type of conditions? Falls, yep. And we also have a change in body composition. So chronic disease like heart disease, type 2 diabetes, etc., can become more prominent. Yeah, so reflexes and balance tends to be impaired, which once again can lead back to an elevated risk of falls. It's a common pattern emerging here. Remember we spoke about muscle fibre types, and I'll go into this very quickly because we are going to cover it in today's lecture. We have type 1 fibres, which are slow twitch. Remember I told you the story about the muscle biopsy? Type 2A, 2B, 2X. and these are all fast twitch fibres. The 2X is a new one, probably been around for about the last 10 years. Now, the differences between these are essentially their ability to contract and how long they can maintain contraction for. So just by virtue of the name, what sort of activities do you think would be supported by slow twitch muscle contractions? Sorry? What type of strength? Usually muscular endurance stuff, so longer term contractions. Yep, what were you going to say? Yeah, marathons, triathlons that require a low level of muscle contraction but for an extended period of time. Beautiful. Now talk to me about the fast twitch, particularly the 2B and 2X sort of activities. Yeah, sprinters, weightlifters, powerlifters. Yep. So weightlifters actually think that any more than 6 reps is endurance. That's their belief set. And if you ever watch weightlifters train with triathletes in the same gym, this is a really interesting dynamic, right? Because the weightlifters will pick heavy stuff up 4 times and then go sit in the corner and talk for 10 minutes. The triathletes, like, these guys don't even work, they're just going and going and going. So it's this interesting dynamic if you watch them train together. Now, tying this back in, what tends to happen from middle adulthood on is we lose our type 2s or a percentage of them. So our loss of type 2s accelerates. It accelerates. Hence tying back into conditions like sarcopenia, which is a loss of muscle mass. And I know myself, it is far more comfortable for me to go and run 10K than to do a HIIT session, because I've lost a percentage of fast twitch fibres. If you go to, who's been to like Gold Coast Marathon or Brisbane Marathon or even a 10K run? Yeah. Talk to me, do you see a larger percentage of older guys in particular? And they're smashing it, aren't they? These guys, I did the Gold Coast Marathon a few years ago, and these guys that are like 65 plus are belting me all over the course. And I'm like, what is going on here? But if you go to a Masters Games at, say, Griffith University and see how many are doing the 100-metre sprint, what do you think you'd see? There ain't many, because it's uncomfortable, because there is a selective loss of these type 2 fibres. So if you want to win a bucket of medals at Masters Games, when you guys get a bit older, go and do the track and field events. You'll have no competition, because by virtue of this physiological fact, most guys in particular tend to go into the long, slow distance stuff. Plus there's more people doing it, so there's more of a social element as well, which tends to become more important, particularly when you hit this late adulthood stage. All right, I won't worry about one stage of psychosocial development, but I do want you to talk to me about one stage of Piaget's cognitive, because I don't think we touched on that in as much depth as some of the other theories last week. Talk to me about one stage.
So that's 7 to 11. It's reasoning becomes logical, but it's not at that stage of understanding abstraction that you develop after that.
So define abstract that then comes in later.
That aren't concrete and solid.
Philosophy, philosophical type points. That's what I was just going to say about moral development. So we're kind of looking in this stage. After that, they start to develop more of a moral compass. They're starting to distinguish between right and wrong, and maybe even forging their own opinions. Identity versus role confusion. That's a very nice marriage between the two, actually, because when we hit adolescence, we see them struggling for that autonomy, and some of Piaget's cognitive development definitely ties in with that. Up to that point in time, it's like a clash for them. Up to that point in time, even if you think about politics, religion, morality, some of these more abstract type topics, they just believe what mum and dad believe. Oh yeah, it's right because mum said it's right. It's wrong because dad said it's wrong. Whereas when they start developing this more abstract, if we look at Piaget's abstract cognitive stage, then they're starting to think for themselves and go, well, hang on a minute. Why? Why is that the case? Oh, no, I actually disagree with you on that. I think this. So they're developing their own thoughts and opinions. So there is this conflict in, well, for the first 10 or 11 years of my life, I've always been taught this is the way it is. Now I've actually got some different thoughts due to my own experiences. So that conflict can be challenging to manage in itself. Any questions or thoughts or comments on those? Good. Now these will set you up nicely for the end of semester exam. So what I'd suggest is just keep your notes and reflect back to these when you're doing your preparation for the exam. They'll hold you in good stead. Now, there was a little task that we didn't get a chance to do, and I'm going to set this as homework so we can plough onto some of the content. So in week 1 on Study Desk, you will see there's a 3-page PDF that I've pulled out around a lady by the name of Sophie, who's a migrant to move to the US. So we're not going to do this now, but just a reminder, I'd like you to dip in and have a read of that case study because it details her journey through these stages. And then I want you to have a look at a few of the questions that I've posed up there with respect to that. Let me just double check to make sure that this is continuing on. Yep. All right, here's where we are at. You should have seen, or you can see a PDF of these notes on Study Desk. So you can follow along with those, or you can make your own notes if you choose. So physical activity is one of the few interventions that can restore physiologic capacity after it's been lost. Last week, remember we spoke about bone density as being one of those qualities, where I mentioned the fact that most research says that BMD, bone mineral density, usually peaks in early adulthood and then it's a steady decline from then on in. But I've seen some anecdotal evidence and there's more research being published now that shows you can actually get an uptake or actually increase bone mineral density even after menopause in women. Estrogen has a really important role to play in bone. We'll talk about that later. For example, and I've got the references down here too for you to follow along. Here's exactly what I was talking about illustrated graphically. So you can see peak bone mass is achieved in that early adult stage. That's a bit controversial. Some studies show that that happens before 30 years of age, but let's assume that that's when we hit our peak bone mass. And then you can see this steady decline. And look at what happens at menopause. Can you see that sudden drop? Because estrogen plays a really important role in keeping these little cells called osteoclasts in check. Okay? If you're choosing to do osteoporosis for your assignment, this will be really important and you'll go to that reference. And look at the difference without treatment and with treatment. So you can see the decline is still taking place, but it's certainly nowhere near as rapid as without treatment. Now, treatment in the case of this study is a combination of physical activity and pharmacological intervention. In other words, hormone replacement therapy, maybe Fosamax, maybe vitamin D as well, plus physical activity. So a combined intervention. I'm an exercise advocate, that's my role, that's my career, but I'll even admit that it needs to be a dual intervention in order to minimise the rate of bone loss. It's never just one solution, it's a combination of interventions. Remember, jump in here at any time. All right, quickly, this will be a quick task. Write down as many systems of the body that you can think of and identify 1 to 2 key functions of each system. So before I mentioned a few, remember we spoke about the muscular system and the skeletal system. So I want you to quickly jot down as many that you can think of, along with 1 or 2 functions of each. Don't stress if you haven't quite finished yet. But I want you to start calling out some of those 11 systems of the body. Good to get in early with the obvious ones. Good strategy. Cardiovascular, love it.
Integumentary system.
Oh, beautiful. I missed one, somebody yelled out. Lymphatic, that was it. Sorry? Renal, yep. Sometimes this is combined with this and called the cardiorespiratory system. So in some sites that you would have looked up, some references, that's what you'll see, cardiorespiratory. Nicely done. Now, one function of the muscular system, what does it do? Movement, so responsible for movement of the body or the skeleton. What about cardiovascular slash cardiocirculatory slash cardiorespiratory? Sorry? Sorry, what was that? Okay, so pushes blood through the body. Why is that important? Or what do we need to extract or put into the blood? Correct, so it delivers oxygen. And what does it get rid of? Carbon dioxide, beautiful. So it delivers fuel and gets rid of waste. Nervous system? Correct. Give me an example of two systems where that might take place. Yeah, nice. So a message might come in the form of an action potential from the nervous system, from the central nervous system down the peripheral nervous system to a target muscle, organ or gland to activate it. Integumentary? Yep. Largest organ in the body, always pops up at trivia nights. Temperature regulation, correct. And as a barrier, so it's a protective barrier from pathogens. Stretching, cool. Respiratory, I think we've already covered. No, tell me a separate one. Separate function for respiratory.
Yes, oxygen into the body.
Yeah, correct. The key word I would use is exchange. So it's responsible for gas exchange. Is that what you were going to say? Well played. Endocrine?
Controls hormones, isn't it?
So the excretion and management of hormones. And what do hormones do? Anyone here have a teenage son or daughter? Be able to explain that quite nicely. But endocrine, hormones have different target organs as well. So it generally upregulates or downregulates a certain physiological function. Digestive? So it delivers, so it's responsible for the breaking down of food and extracting the nutrients to be taken up by the various cells. Or pass straight through, like most supplements. Skeletal? Support structure, so like a framework for the muscles to hang off essentially. What's one other important function of the skeleton? Because I think we sort of covered movement support up here.
Protects like your lungs.
Yeah, exactly. So think about the rib cage, sternum, scapula. They all have a huge protective function. Cranium. Circulatory, I think we've covered. Lymphatic.
Is that your immune system?
It's a part of the immune system. Yeah, really important part of the immune system. Anyone hazard a guess as to what it actually does or how it improves or manages or monitors our immunity? That's a very good description. So it's a big filtration system. So wherever you have blood vessels, you also have lymph vessels. Who's been to the doctor with a cold or a flu type and they do this? Maybe under here and also in your groin. You have these clusters of lymph nodes. And when you're fighting off a bacteria or a virus, those lymph nodes puff out and get bigger. They're like factories trying to process all the junk, all the bacteria that often our white blood cells have killed. They dump it into the lymphatic system to be processed. So these little factories are going crazy. And that's when you start to swell up there, when your immune system's trying to fight something. Function of the renal system? Yeah, it gets rid of waste. Exactly right. Well done. So now I'm going to show you this little clip now. Ignore the fact that this is animated. Some of the info on here is actually not bad. So this is a very quick run around the systems of the body. Just try and ignore the funky music at the start and the end of that. All right. So that was just a debrief on the first task. Now what I'd like you to do is to come up with 1 or 2 changes that occur with that system as we age. So far we've come up with what the systems are, and you've told me one kind of role of each of the systems. Now I want you to expand on that a little, and for each system, explain how that might change over time. So I'm going to keep this up here for you to refer to the stages of growth and development. And then try and think of 1 or 2 changes that can occur when pathologies are involved. So 2 parts. This actually replicates your assignment, which is why I've put it in here. So 1 or 2 changes that occur with each system as we age. So normal deterioration or change. And then think about, well, if there's a pathology involved. What do you think I mean by a pathology? Yeah, so a disease or illness or a condition. So things like sarcopenia, osteoporosis, type 2 diabetes, etc. So this will take you a little bit longer, and I'm happy for you to work as pairs or groups of 3 to get this one done. But after this task, you should have a much clearer idea about where you might want to head with regards to your assignment and what I'm looking for in that task. Any questions on what I'm looking for you to do now? We good? Remember, you can collaborate with this, and I'll give you, let's go till 10:30 for this. We'll do a quick debrief and then we'll have a break.
In the later, middle, late adulthood.
Yep. Yep.
It can be genetic.
Yes. So if we're talking about osteoarthritis, we generally tend to see it in middle and late adulthood. However, that trend is starting to change a little bit in recent years. Who's heard or knows of somebody that might have been diagnosed with some degree of osteoarthritis in adolescence or early adulthood? Yeah, so talk to me about that.
I think that tends to be connected because we looked at the lymphatic system and it's an autoimmune disease. So you can develop that earlier, and that's probably usually more what it is for lymphatics as far as developing.
So we're talking rheumatoid arthritis or osteo?
Pretty sure it's both. It's usually more RA.
Correct. Yeah, rheumatoid is more of an autoimmune one. So let's talk about the difference between the two. So an autoimmune condition like rheumatoid arthritis is where the body's immune system attacks itself. So it sort of identifies a particular aspect of the body and goes, well, I think that's foreign, I'm going to attack it. So what happens with rheumatoid arthritis is the lining around the synovial joints gets attacked by the white blood cells, right? And you generally look at people and they have, it's usually symmetrical. So you look at their fingers with rheumatoid arthritis and they sort of curve all one way. Yeah, yep. So, and it looks like you've got like some abnormal growth on one side of the knuckle and it makes it bend the other way. That's rheumatoid for you. Whereas osteoarthritis, osteo meaning bony tissue, is where the cartilage that surrounds the ends of the bone starts to degenerate and break away. So it's more mechanical than autoimmune. Not so much rheumatoid. Osteo can be due to too much. So the opposite. This is where I was leading back to, right? So let me explain the pathophysiology, if you like, very briefly for osteoarthritis, and then I'll tie it back to why we see it earlier. So if you've got 2 bones, so imagine this is my femur and this is my tibia. Often happens, Paul and I were talking before, in the lower limbs, in the joints of the lower limb, because you have the femur and the tibia, and if you're carrying more weight, what happens is you have more compression and more impact, and the cartilage, it's called articular cartilage that surrounds those long bones, starts to grind away and degenerate. And that's when you've heard of people say, I get bone on bone. That's essentially what they're talking about, is that articular cartilage has kind of worn away. So now that we have an increased rate of childhood obesity, and yes, we are catching America in these stats, so kids are heavier purely from a mechanical perspective, think about what that's going to do to the weight-bearing joints of the lower limb. So think about how that articular cartilage can be worn away quicker. Make sense? So if you are choosing osteoarthritis, you can choose to be really focused and go, well, I'm not just going to do this middle and late adulthood because there's so much done about that and it's got lots of publicity, but wouldn't this be interesting? Even late childhood, adolescence and early onset osteoarthritis. Check out AAHW for that, if that piques anybody's interest. Interesting stuff. All right, I'm not going to talk too long about this slide because it just talks about the advantages of exercise for some of the main systems of the body. It's more there for you to reference just as a debrief from the previous task, okay? So I'm not going to spend too much time talking about that. This slide goes, if you do want, I've put a link, I'm pretty sure I put a link to this one up on Study Desk, but if you want the URL, just send me an email and I'll add it through. This highlights some of the exercise physiology responses. So looking at some of the systems of the body and really simply explaining some of the changes that take place when we add physical activity to a person. And I just want to pick on oxygen transport, which relates to which of the systems that we spoke about before? So respiratory, circulatory, yeah, cardiorespiratory, any of those sort of terms would be the correct answer. So looking at increasing oxygen uptake, which essentially means as the blood is coming past the muscle, we can suck more oxygen out of the blood. We can become more efficient. One of the big things that Lance Armstrong got better at, you know, the cyclist who was done for EPO and drugs over basically his entire career. If anybody's interested, I do have a paper that his physiologist released towards the end of his career that shows all of this data, like his VO2 and his efficiency and whatnot. If you're a bit of a science nut like I am and you want me to send it to you, flick me an email and I'll send it through because it's really interesting. So looking at the ability to improve oxygen transport and delivery. So we can increase our max heart rate and our cardiac output, which is the litres of blood per minute that we can pump around, right? So we get better at that. And we can increase our ventilatory rate, so the number of breaths per minute, which means we can then saturate our blood with more oxygen to be delivered during physical activity. Does that make sense? So we just become a more efficient engine, essentially. Right, so I'm now going to look at cardiovascular changes. That's where we're going to spend most of our time, but we will zero in a little bit on muscular strength, flexibility, and a tiny bit on body composition changes across the lifespan as well. All right, so now looking at CV is cardiovascular in the heading. So pre-adolescent children, improvements are related to growth and mechanical efficiency of walking and running, not cardiovascular training. Not cardiovascular training. So in other words, through increasing their lean muscle mass and the growth of their limbs, they just learn to move better. They're not improving their max heart rate. They're not improving their cardiac output. The cardiovascular system itself isn't leading to those improvements. They're learning to coordinate their limbs better so they can run further. Does that make sense? Remember when we used to teach Auskick? Does anyone have their kids or seen someone that does Auskick, you know, the AFL junior program? We used to run that at local primary schools. It'd start at 3:30. So you imagine a group of boys in particular that have been cooped up in a classroom for 6 hours. They'd come running down towards the oval and we were like, holy smoke, what's going to hit us here? And there was a tree about 400 metres the other side of the school. We'd say, just keep going, go run around that tree and then come back. And they'd come back and they were puffing, but they could have done that all day. You know what young kids are like? So I say young kids, I'm talking sort of late childhood and early childhood as well. They can just keep going and going and going. And this is one of the reasons why. In adolescence, we start to get a steady improvement in cardiovascular capacity due to training. So their cardiovascular, their cardiorespiratory system is more responsive. So you can start to increase red blood cells, you can increase ventilation, lung tissue becomes more elastic, those types of adaptations can start to occur. And look at this third point, an adult can improve cardiovascular ability as much as 20% with training. Just pulling back to the Lance Armstrong story, we know that cardiovascular capacity, or VO2 max, is around 50% due to lung function, which is largely genetic. So choose your parents well if you want to be an endurance animal like Lance was. The way where he started with his base VO2 max, so not training, Lance sitting on the couch, his VO2 was about what a highly trained male average person was. Imagine that for a head start, purely due to your genetics. So an average male, just to put some numbers around this, not trained, VO2 max, so the maximum amount of oxygen that you can consume per minute, per kilo of body weight. Let's say it's around 30, 35 millilitres per kilo per minute. Have you done any sort of physiology yet? Or am I talking gobbledygook? A little bit, yeah, you can see that. So the average male, mils per kilo per minute. Okay, Lance sitting on the couch doing nothing, he sits around 65. Not a bad head start, hey? That's where this guy's going to get to when he trains his backside off. He'll get to Lance's couch VO2. And then Lance cranks up to around 90 was his best mils of oxygen per kilo of body weight per minute of exercise. Not the highest though. Certainly wasn't the highest on the tour. Cross-country skiers get higher than that. Simply because they use more muscle mass too. There's upper and lower body, whereas cycling is more lower body, obviously. Now, look at this last point. This is important, particularly if you're choosing a condition like chronic obstructive pulmonary disease or asthma for your condition for your assignment. Decline in cardiovascular in adulthood is dependent more on the intensity of training and disuse than duration of training. Remember our little chat this morning around muscle fiber types, fast twitch versus slow twitch? So this is saying that when we hit middle and late adulthood, we should be doing more HIIT type training to minimize the loss of cardiovascular function. So all those older guys we spoke about before that are down at the Gold Coast Marathon, that's great. But to minimize the decline in cardiovascular function, they should be having some HIIT training along with that. But do they like doing it? Usually no, because it's uncomfortable and it hurts. I can speak from experience. All right, now, these are just some normal vital signs. So you certainly don't need to memorize these, but it's just interesting to see from a growth and development perspective how certain markers change over the stages of growth and development. So look at the pulse. Newborn, this is heart rate, hums along between 70 and 190 beats per minute at rest. Does anyone know their resting heart rate? What do you sit at normally? Put you on the spot now. 50? 60? Yeah. 60 is generally sitting okay. I usually get clients, if they're monitoring this, to monitor their adaptation to training when you first wake up in the morning. Radial pulse, count how many beats in 15 seconds, multiply by 4. And I get them to keep a diary of that every day so I can see changes in it. So for example, if you're about to get a cold or a flu, like an upper respiratory tract thing, before the symptoms appear, before you get snuffly and a sore throat, etc., your resting heart rate will bump up a bit because that's one of your immune system's responses to trying to fight that pathogen. It's going to increase core temperature is another one. It's going to increase resting heart rate. So if you normally sit at 60 and then 2 days in a row you're 68 and 71, you're like, oh, well, I haven't changed anything else. Maybe you're about to come down with something. So you can be more proactive and back off on training and whatnot before the symptoms appear. Make sense? This 190, the pulse rate in newborns, is generally when they're crying. And the same with infants. So 80 to 160. Don't be alarmed, their heart rate does go through the roof. Toddlers, you can see a broad range there, 80 to 130. Preschool, 80 to 120. Adolescent starts to come down. Adult, 60 to 90. I've assessed some guys with a resting heart rate of around 100 beats per minute, which ding, 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 say, okay, let's just check your blood pressure. As a matter of course, it just means that their ticker is working overtime at rest. So imagine overlaying HIIT training on top of that. That's not going to be a good outcome for anyone. Respirations is simply breaths per minute. So it follows the same pattern. Your respiratory rate is higher during the early stages of growth and development, and it decreases as we improve our respiratory efficiency as we age. Excluding disease. Get somebody with chronic obstructive pulmonary disease. As an older adult, that will be closer to 30. So they'll be to try and get a decent volume of air in. Temperature, don't worry about that. That's Fahrenheit rather than Celsius. But look at the BP. Systolic over diastolic. So systolic is when the heart is actually in systole or contracting. Diastolic is between beats, so when the heart is resting. The one that I place more importance on is the second figure, the diastolic, because if the pressure in the heart is up when it's resting, then I consider that a more serious issue. So normotensive or normal blood pressure, just for your own records, this might be useful to write down, is 120 over 80. Mild hypertension is 140 over 90, and then you just go forward from there. One of our ex-physers did an assessment on somebody last week, and his resting BP was something like 210 over 120, something like that, which was not a good figure. Yeah, that's serious hypertension. Once again, it just means that there is some obstruction or there's some abnormal functioning of the cardiovascular system to result in that elevated BP reading. Keep in mind, if you are testing some of these things on yourselves, or you've got a parent or a grandparent who usually has the at-home blood pressure monitor that they do every morning, it will be affected by a food intake and particularly caffeine. So if you are going to keep an eye on some of this stuff, do it before you have your morning cup of coffee. I generally tell people, I give them a diary of stuff I want them to record, and I'll say this must sit beside your bed on your bedside table, and you've got to do it before you get going in the morning. Get up and have a wee, then come back and do all this data for me before they have a coffee, because that's going to elevate both blood pressure, systolic in particular, and heart rate. I'm not going to worry too much about the cardiac output overview video. You can have a look at that in your own time. But essentially, cardiac output is how many litres of blood per minute circulates around the body. So if you want to write that down, you can. It's how many litres of blood per minute circulate around the body. So this graph on the right of the slide here shows cardiac output in litres per minute along the y-axis and age down the bottom along the x-axis. And you can see for males and females, males are red, females are blue, the age-related change. So this is excluding training. So this is normal age-related decline of cardiac output. So you can see like an average figure here is 6 litres per minute, 6.5, 7 litres per minute during exercise. That can march north to about 20 to 30 litres per minute. There is an equation I want you to write down for cardiac output too, and I'll put it up here. So cardiac output equals heart rate multiplied by stroke volume. I need you to write that down. Heart rate multiplied by stroke volume. And we measure this in litres per minute. Heart rate is obvious, you will understand that. What is stroke volume? What's this thing? Yes, so heart rate is beats per minute. Stroke volume is mils per beat. Now imagine this. You've got somebody with metabolic syndrome, they're obese, they've got type 2 diabetes, they've got poor physical activity, they've got a genetic history of heart disease, etc. Their heart, their left ventricle, will have less elasticity. So when it goes to fill, when that left ventricle or that chamber goes to fill, it's going to stretch a little bit and it's got poor contractility. So when it goes to force the blood out, it just gives a little push. Correct. Whereas you get somebody that they're highly trained and they have an elevated VO2, their cardiovascular system's well adapted and responding well, that left ventricle will stretch more. So if you can open it up more, do you think you'll fit more fluid in? Yes. And if you stretch it more, it's going to snap back quicker and get a more violent sort of contraction or ejection. So can you pump more blood out? Yes. So what do you want on your team? Do you want this? Or do you want that? Obviously you want the second. So if you can have a good stroke volume, that's obviously going to influence your cardiac output and it's not going to cost you as much in terms of heart rate. Does that make sense? So to crank out 6 litres per minute at rest of blood around the body, if your left ventricle's like this, how many times is it going to have to beat to crank out 6 litres? It's going to have to do a lot more work. So if you're Lance Armstrong sitting on the couch with your 35 mils per kilo and you've got a stronger left ventricle, you can extract it more. Do you have to beat it as much to get your 6 litres? No, so you are more efficient. Stop me at any time. All right, across the lifespan, CO is cardiac output, is less in children than it is at adults. At rest and during exercise. So I've put in there adult average resting cardiac output's about 5. I'd actually write 5 to 6 litres per minute is an average resting cardiac output. And there's your figure for trained adults. The exercising output can crank up to 20 to 35 litres per minute. And it can reduce by as much as 58% from the ages of 25 to 85. So obviously we're talking about from early adulthood into late adulthood, we can see a significant drop, usually about 1% per year after 25. So use it or lose it, essentially. And you know what? You speak to older adults and they'll come into your clinic or you'll see them for an appointment, and I'm generalising here, but they'll say, I walk every day. And I'll go, that's fantastic. How long have you been walking for? 20 years. Great. How far do you walk? I do 5Ks. Great. Have you always done 5Ks? Yep. Do you go the same route? Yep. Do you change the intensity? Nope. And they're wondering why they're not improving anything because they've reached a plateau. It's like the definition of insanity, isn't it? What did Einstein say? Insanity is where you do the same thing and expect a different result. So the body is only going to adapt to meet the demands that you place on it. All right, heart rate across the lifespan. We've referred to that table, so I don't really need to talk too much about the figures. But from adulthood, MHR is max heart rate, declines by almost 1 beat per year. So my max heart rate would certainly be less than yours that are younger than me. Now, what happens as we age, our coronary blood vessels and our other blood vessels become a bit more brittle. So the cells around the lining of the vessels can't expand as much. They're not as stretchy or pliable. They get a bit brittle and stiff. So if you can't open up those vessels as much, can you pump as much blood through? No, you can't, which is why it's so important to exercise through that crucial early adulthood, middle adulthood, late adulthood period. You've got to make the heart elevate and pump some blood through those vessels to keep them elastic and stretchy. I remember one of my professors when I did my master's years ago, he was an older guy. He would have been about 75 at the time. And he'd finish a lecture and he'd say, right, I'm just off to clear the vessels. And all he would do was go for a run around the campus. Because he understood, he was a physiology nut, right? He understood that whole thing about the blood vessels becoming brittle with age. So we'd always try and keep them pliable by pushing more blood through them. We use the analogy of a hose. If you turn the hose on one turn, you push a certain amount of fluid through and the hose sort of gets a little bit fatter. If you do 3 turns, what happens? The hose stretches a bit more to allow more fluid through. When people have heart disease, kink the hose and you can feel the pressure build up behind the kink. That's essentially what happens in the coronary arteries. So just think you want to prevent the kink. When you're talking with older adults, use that analogy, they'll get it. All right, so here's some more data on stroke volume. Remember, we already established that stroke volume is mils per beat or litres per beat. So trained individuals, this is the main difference in overall VO2 max or oxygen capacity. Trained guys and girls have a much greater stroke volume because they can expand and contract more powerfully. Women have a lower stroke volume from men purely because of the fact that they have less lean muscle mass. Men have more mass, so therefore they can generate a greater stroke volume and their cardiac tissue can stretch a little bit more. Now, if we have a look at this data, this shows you the difference between untrained, trained, and elite. So look at the untrained, which is the diamonds. So you can see his stroke volume in mils per beat along the y-axis. Here's the untrained guys. Look at the elite guys. So all about the same at 110 beats per minute. So you get a couch potato, an elite athlete, and a trained average person all to go for a run together. Everything's pretty level in terms of stroke volume around that 110, 120 beats per minute. But then look at what the elite guys do. Can you see how they crank up their stroke volume? So they're not increasing their heart rate much, but they can go up, you know, around 160, 170, 180 beats per mils per beat. Yet the couch potato, they can't stretch as much with their left ventricle. So they're like, holy smoke, I better work harder to generate the same, 20 litres per minute. So they're like this. Whereas the elite athletes are like this. So their heart rate doesn't have to increase as much. Does that make sense? Beautiful. All right, so off the back of stroke volume, here's our max VO2. So here's some data for you. Children less than 6 have a maximum volume of oxygen consumption of between 22 and 28 mils per kilo per minute of exercise. Kids from 6 to 16, that cranks up noticeably, 50 to 53. Girls will be less than boys at 16 years, purely because of the increased muscle mass from puberty. And the VO2 max can drop as per stroke volume, so between 0.5% and 1% per year, due to change in body composition, so less lean muscle mass, more fat mass, and decreased levels of physical activity. Look at this stat. To live an independent lifestyle, not being in a wheelchair, an elderly person requires a minimum VO2 max of 20. So essentially back to what it is when you're less than 6 years of age. But can you see if you invest more effort here, you're not going to run into the problems here. And look at that graph over on the right. VO2 max along the y-axis, age along the x. Females red, males blue. Look at the drop off. This is without training. And you see from the age of, where are we, about 30, 35, look at that decline. And it's a mirror image for males and females. You want to arrest that decline, unless you want to end up in a wheelchair. Look, below 20. Here's 20 mils. All right, before we move on to strength, any questions around cardiovascular or cardiorespiratory across the lifespan? That was a really quick whip around, but ultra important. Strength is getting more focused, particularly with older adults and with kids. So we're going to have a look at a position stand-on resistance training with kids, youth and adolescents in a minute to reinforce this. We don't know much. There's little published literature on strength training for kids in early adulthood. I reckon there's going to be some more work in this space as researchers and public policy starts to look for a solution to the health issues we're experiencing now in adolescence and early and middle and late adulthood. We're sort of looking at what we can do earlier. So I reckon there will be more work done in that space. So this is interesting. The strength spurt lags at least a year behind the height spurt. So you know when kids shoot up, it's called their adolescent growth spurt, or AGS. I'd write that down if I was you too. Adolescent growth spurt. So the strength spurt doesn't happen for another year. This is where kids go through this gangly stage, where all of a sudden their legs and arms go whoompa and they grow, and then the torso stays about the same, but the limbs grow, and then the kid's like, oh, I feel like I can't even run, because they've got to learn, their nervous system has to learn to coordinate different shaped limbs now. And I remember this feeling myself. It was like, you know, the road runner when he spins his wheels and he's just not getting anywhere for the first 2 seconds. It kind of felt like that. No matter how hard you try to run fast, you just can't. And it feels like you're trolling through peanut butter when you run. You know what I mean? You're really dragging your backside along. But then the strength spurt kicks in a year later and you can pick up that deficit and all of a sudden, oh yeah, I've got things down pat. I can run fast again. All right, so strength, girls hit their spurt in the same year as the growth spurt, right? So that adolescent growth spurt, girls will hit the strength spurt earlier, and they'll also hit peak height velocity earlier. And this leads to some social issues in the playground, doesn't it, right? Because around the ages of sort of 10, 11, 12, the girls shoot up and the boys haven't started yet. Generalisation, of course. And then the girls sometimes go, holy smoke, what's going on? Sometimes there can be a little bit of embarrassment. The boys are like, whoa, whoa, what's going on here? She was my height last week and now she's like a giant. So obviously some of the changes that occur around adolescence are based around the endocrine system when we have puberty. Boys start to release more testosterone and more growth hormone, which increases lean muscle mass. Girls release more estrogen, which doesn't produce more muscle mass. So we start to get a lot of this change in function around puberty purely as a result of the endocrine system and the changes that brings about. But muscle mass begins to decline anywhere between 25 and 50 years of age. So that's a huge bracket, isn't it? So if you're looking at sarcopenia, which is essentially a loss of lean muscle mass, that can happen in a primary or secondary form. Primary is it happens by itself with no other pathology. Secondary is where it happens as a result of a condition, for example, an ACL rupture or an injury. Look at this last stat. By 80 years, one will have lost half of their muscle mass. Now, that's a generalisation. The application of strength training early on can arrest a lot of that loss. And I've seen this happen with older adults. So not only arresting the loss or slowing the loss in bone mineral density, but also the loss in lean muscle mass. Both of those things lead to huge public health issues. There's the link there. This is an ultrasound of a thigh. And look at the white stuff is fat. The dark grey stuff is muscle. So look at the difference in body composition between your 25-year-old and your 63-year-old. See the increase in body fat? This is a cross section, right? So this is the femur. And you'd have your quadriceps. This is probably your quadriceps. These are your hamstrings around here. Look at the increase in fat mass. Subcutaneous fat around here. And you can see there's increased marbling of fat through the tissue itself, just to illustrate some of those body composition changes. All right, resistance training. I just want you to look at the graph here. So here's bone mass along the y-axis and age along the x. Peak bone mass, as we discussed previously from that earlier chart, happens somewhere between sort of 25 and 30, some say between 22 and 30 years of age. And then we have this decrease in bone mass as we get older, a more noticeable loss of bone mass around puberty in women because of the important role of estrogen, which is why hormone replacement therapy is so important. So we're going to cover off on some of these bullet points here around resistance training for youth and adolescents in a second, all right? Small group discussion task. Children under 16 years shouldn't perform resistance training. Do you agree or disagree? I'm actually going to skip through this and point you towards the forum that's already on Study Desk. As I said earlier, there are a couple of comments on there at the moment. But just as a quick sort of poll, who agrees with this statement? Children under 16 years shouldn't perform resistance training.
Is that resistance training with weights?
Yes. Yep. 13?
12, 13.
Yep. Yep. So what makes you say that? Yep. Yep. Yeah, okay. Yep. Yep. Fair enough. Yep. And we all know, who was it that said boys do stupid stuff earlier? Yeah. Boys do stupid stuff. So the supervisory requirements probably need to be considered. Who thinks that we can?
Yes. Yeah. I think I did some of the readings and talking about avoiding one rep max stuff because of bones, but doing scale resistance training, that's fairly controlled and specific.
So what are the benefits of some of that? And this is open to everybody. What are some of the benefits of doing a well-designed resistance training program? Yeah. So it can actually increase coordination.
Teaching technique.
Yep.
Before they're of an age where they might want to do one rep max.
Yep.
You put that technique down.
Yep, absolutely. Any other thoughts? What about self-esteem, self-efficacy? And does it always have to be dumbbells and barbells? Body weight's a resistance, isn't it? And this is what parents will come up to you and this is what you'll get, right? I've had this a lot. My little Johnny isn't going to lift weights because it's going to stunt his growth. Who's heard that before? A number of times. The research shows, and in this position stand I'm about to show you, there's some evidence of that. The research shows that in very few cases, and only where youth are lifting around 1 rep max without adequate supervision, has any damage to the ends of long bone been validated. Most reported injuries in a resistance training environment are from people not putting the weight plates back on properly and getting a finger squished or dropping a dumbbell on their toe. Most reported injuries in the weight room are that, not, oh, I've suffered a fracture and I've actually stunted my end plate's broken because I've been lifting weights. So just be aware of that as well. It's really interesting because I'll guarantee you remain in this industry, parents will come up to you and they will make that comment. Because it's like an urban myth, you know, it just gets passed down from generation to generation. All right, I am going to get you to do some research around this. So let's look at the task and then I'll give you some more info. Research the levels within the Australian Strength and Conditioning Association position stand, which is on Study Desk on resistance training for child and youth. And we've got 4 levels here. Level 1 between 6 and 9, level 2, 9 to 12, level 3, 12 to 15, and level 4, 15 to 18 years. And what I want you to do is to analyse what those competencies are or what the standards are that the ASCA say you should achieve within each age bracket, and then explain to the rest of the group what they are. For example, one of them is a plank or a bridge. Hand up if you know what that is. You know, a bridge or a hover, a plank. So one of the competencies in this position stand states that if you're between 6 and 9, you should be able to hold a plank for X number of seconds. If you're between 9 and 12, you should be able to hold a plank for Y number of seconds, etc. Now, let me show you where you'll get that information from. I'll get rid of that one. So if you go to study desk, I've actually put a lecture up there. So here's the position stand here that you can have a look at. It is in there. And if you look at this reading as well, conditioning for rugby league, I'll pull that up. Here's a summary of the position stand. And here are some of the criteria, right? So if I look at this one, level 1 competency, 6 to 9 years. Here are the 7 competencies for that age group. So the info that you're looking for is in that presentation on study desk, and it's also in the position stand. So you've got access to both in there. I'll go back to that one. Any questions on what I'd like you to do before I split you into groups? No, we're all good. Okay, so we need our first level, 6 to 9 years. Why don't we we might have to split this row in half. So the first 1, 2, 3 rows here, you guys can do 6 to 9. The back 1, 2, 3 rows can do 9 to 12. The middle row here can do 12 to 15. You guys can do 15 to 18. I'm going to give you 5 minutes to read and understand what those competencies are. Then I'm going to ask you to run through them with the rest of the group. You may or may not choose to demonstrate. It's going to be up to you. All right, away you go. All right, just to finish off today, I want to talk about this slide for literally 1 minute. This is from the Australian Institute of Health and Welfare, so you can see the reference down the bottom. And this data shows us overweight and obesity by age group and sex, 2014-15 data, males versus females. Males are the darker columns. And what I want you to pay attention to here is the trend that obesity follows. So look at the general curve, where it starts to increase. 18 to 24, we start to get a spike up, particularly for guys, between 2 to 17 and 18 to 24, so in early adulthood. And then look at how it stays up, right up until 74 years plus. You know how we were saying if you go down to the shopping centre and you look for the skinny 90-year-olds, look at what happens at 75 plus. See the drop-off, particularly in guys? More of a noticeable drop-off than for the girls. And look at the difference in middle age. So from the age of 25 through to 74, look how much more prevalent obesity and overweight is for men than women. That's significant. All right, so that kind of rounds us back to where we were talking about right at the start. All right, we might wrap it up there. Thank you for your attention.